We have Dr. Inderpaul Singh with us today. He is an eminent chest specialist from PGI Chandigarh, and he has a very keen interest and research publication in ILD. So you have talked about ILD in developing countries today. So tell me the scenario of ILD that is there in developing countries.
Well, to begin with, let me tell you that diffuse parenchymal lung diseases have been thought of being very rare disorders. Unlike the current global disease burden report, which suggests that it stands at the position 40 in terms of life years lost, and there is a 86% increase in the prevalence and incidence of DPLD if you look back way back in 86. And unfortunately, we do not have much data regarding this disorder, not only in India but worldwide. And especially most of the epidemiological studies have been way back before 2012, when the diagnostic criteria have been updated for various ILDs. So we feel that definitely there is a need for knowing much more regarding this disease, and perhaps this is what we were trying to look for. So when I searched the PubMed, we found that there were 6 studies that have been conducted from developing countries as defined by yearly income of $1,000 to $4,000. 4 studies were from India itself, 1 from Turkey, 1 from Pakistan. In general, most of these studies are either single center or multiple center studies. The problem is that they do not provide us a follow-up data of whatever they have, and they provide the data which may be center specific, like I am seeing something, you are seeing something, so we may both be right in our perspective, but whether we both are right in everybody's perspective may not be true, and it may not give a true picture. Even the Indian registry had this problem, although it was multicentric, but the number of cases from each centers was variable. Some of the centers provided data of even less than 10 patients, some even 1 patient during the entire study period of 2 years. Although this is the largest study that we have, and we have to accept the results that they have given. Unfortunately, that they have given a hypothesis that the hypersensitivity pneumonitis, which in fact was the commonest type of DPLD, which is glaringly distinct from all the data that we have, not only in India, surrounding developing countries, but the entire world, which says that sarcoidosis followed by interstitial pulmonary fibrosis, idiopathic pulmonary fibrosis, and other types of idiopathic pulmonary fibrosis are much more common than HP. They provided a hypothesis that this is being caused by exposure to air coolers, which in fact was surprising to all of us. In fact, even the editorial comment that was accompanied by the main publication was cautious. It warned us to be cautious in accepting the results. The hypothesis was might be true, but we need to prove it. They tried doing that by showing aspergillus growth in the air coolers. Unfortunately, aspergillus is a ubiquitous fungus, and it is there everywhere, even in the air. So, and that is further highlighted by the fact that the fungal spore count in Jaipur per se is very high, as documented at one of the website of the leading authors. So, cutting the story short, we feel that the story is not yet over. We need to incorporate more patients consecutively. Another flaw of this study was that they had a minuscule biopsy rate, which is surprisingly low as compared to all other registries. Perhaps they could have increased more number of biopsies to prove their hypothesis. They might have just performed serological tests that would have actually substantiated their hypothesis that the actual exposure is due to air cooler. Going by their concoction of things and explanations, it would mean that we have to, ask the patients that you need to stop exposure to air coolers, because air coolers are being used widely in the country, and if they are the agent for HP, we need to remove that. But frankly speaking, we all doubt that there is any truth to that, and it needs to be proven by further enrolling more patients. Another flaw with the Indian registry was that the CT protocol was not standardized, and if it is not standardized, you may interpret the CT wrongly. The majority of diagnosis was made on the discussion between the individuals, which is otherwise called as multidisciplinary team discussion. Unfortunately, the evidence suggests that there is disparity between the MDDs also. So they also, the level of the kappa value is 0.24 or 0.2, which I would say is only fair agreement between the MDDs. So there is not a good level of agreement within multiple MDDs, and this has in fact been proven in studies that to diagnose HP, the agreement between various MDD is rather poor. Another flaw was that the diagnosis of HP was primarily based on CT findings, and there is evidence to the contrary, that if you use only CT scans, you're likely to misinterpret CTs of IPF as HP. So there is evidence to that. Finally, we believe that the true picture is still not clear. The most common diagnosis or most common DPLD that is prevalent perhaps is towards sarcoidosis and IPF and other IIPs, followed by HP. We all may be in between. There may be something in between. So we still need to, I think, follow up our patients regarding this.
Singh, you are also running an ILD clinic, and PGI also published its data regarding the ILDs. Tell me something about your data and your experience about ILD in developing countries.
So we also published the similar kind of collection of cases. To be frank, ours is a single center. Although in 2 years we were able to enroll 800 odd patients, and in 3 years the Indian registry registered 1,000 patients. So there was only a gap of 200 patients. And we found that sarcoidosis was the most common disorder, followed by IPF at our center. And if you take out stage 0 and stage 1 sarcoidosis, even then the prevalence of and the incidence of sarcoidosis is fairly high. Another strength of our study was that we provided both the incident and the prevalent cases. So we included the new diagnosis and the cases that were already following up in our clinic, and there also, if we compare between the prevalent and the incident cases, the scenario of distribution was almost similar. And surprisingly, the results of our study are in sync with all the other registries and experiences around the country, in the country, and in the developed countries. But the fact is that our study also has a selection bias, a referral bias. We get a lot of patients referred for sarcoidosis, so that may be a flaw, and in fact is a flaw of the study.
So considering that there are ILD registries, there is data from ILD centers, people are really confused whether we try to differentiate these ILD into different categories or we just give treatment to these patients. So what is your key messages to the budding chest physician that how to approach an ILD patient rather than going by that what is most common, what is less common, how to approach these patients so that a proper treatment can be given to these patients?
See, as far as approach is concerned, you broadly classify your ILDs as this is how I do it, whether you are going to give steroids or are you going to give the anti-fibrotic agents. So if you are able to broadly classify or stratify these two group of patients, I think your job is done. So to identify who are going to benefit from your anti-fibrotic agents, you have definite CT criteria to diagnose IPF. So in those cases, you need not do anything. You just follow what the studies have done and you start the treatment. In patients in whom you have either inconsistent UIP or not consistent with the UIP, or probable UIP, there perhaps you need to bring in biopsy, especially in the probable UIP, because some of them will turn out to be HP, some of them will turn out to be sarcoidosis, and some of them actually will be IPF. So I think in this set of patients is the role of biopsy actually. There also, if your patient is a male, a smoker, who's aged more than 60 years, the chances of patients with a probable UIP pattern on CT are that this patient actually will be having a UIP pattern on pathology. So you can easily exclude those patients also out of biopsy, and perhaps perform biopsy in a very select group of patients. If you are to ask me, how do you do on a day-to-day basis? As far as the registries and epidemiological studies are concerned, you definitely have to perform more biopsies, because you want to give a true picture of what is existing rather than you just giving a guesstimate.
Thank you, Dr. Inderpaul Singh, for talking to us and being a part of PACS India 2018. Thank you very much.